Yeah, thank you again for taking the time this morning. This is new strategies to control healthcare costs and increase employee engagement. This is kind of our COVID-19 edition. So we're going to, break down a lot today, talk a little bit about just, what you can do as an organization. Presenting, it's myself, Riley Anderson, and Dan O'Doherty. We are the principals of CS&W Benefits. We're a local independent agency here in Portland, really focused on the small to medium size, size organizations. And in Oregon and Southwest Washington, we've got about 500 clients. And so, we see all sorts of different plans and, where the future is going with all this stuff. And so, again, we're really excited just to share with you some of the strategies, that we've adapted with our clients and things that are working. So, the goal at this is really, what can we do, to pump up the benefit program a little bit? How can we attract, retain, reward employees? And at the end of the day, probably a lot of y'all are looking at that bottom line, costs are just continuing to go up. So, what can we do to try to bend the trend? So I think with that, we're going to just kind of gauge a little bit of who's in the room. So Dan, we're going to do a quick survey here, kind of see what size organizations.
So you should see a poll up on your screen. And I'm getting used to this technology, so it's go ahead and answer those questions. Then we got one more. Okay. Got a few more people who haven't voted so far. If you get a chance, just start punching buttons, everybody. Even if you're staff, go ahead and do something. Okay. Okay. So that's the poll. So this is the number of employees in your firm, and here's the results. So most of the folks in the room, so it looks a couple small groups under 10, 10 to 25, 25 to 50, 50 to 100, and then 3 that are 100 plus. So that's who's in the room right now. And I got one more question here. Go ahead and this should be on the screen though. So this one should be, select the industry that best describes your workplace.
Well, that's loading. This is great. It looks like we've got, multiple size organizations, and we're really going to touch strategies on for all of you. So I like to see that.
Okay, so I'm going to end the polling, and then you should see the results up on your screen. So got a couple nonprofits, 2 nonprofits, 4 that are in healthcare, 2 are in technology, a couple in the financial services, 1 in construction, and then a couple not listed. So that's going to it. So, so that's where we're at right now. And just as an aside, when it comes to employee education meetings and things like that, and we're going to be doing, Zoom meetings and stuff, I think polls like this during an education meeting, we'll talk more about that, are kind of helpful for the employees to keep them engaged throughout that education meeting process.
And Dan, Jennifer piping in here, there was a typo in that poll and we actually left off manufacturing, which is one of our biggest segments. So sorry about that, manufacturing people.
Sorry, folks. Okay.
All right. And so I think with that, Dan's going to kick this thing off. And it's going to be a little doom and gloom here at the beginning, but this is just kind of the current state of healthcare and what we're seeing out there. Okay.
So I think pretty much everybody in the room has to deal with benefits in one fashion or another. So healthcare spending expected to be 19.7% of GDP in 2026. I think right now it's about 17% of GDP. So it's still climbing and becoming a very large number. And I guess from our perspective, as we work with our clients, it's a little bit scary. Healthcare costs are reaching unsustainable levels, jeopardizing America's competitiveness, burdening families. Healthcare is burdening families with their premiums and cost shares and things like that. So I think most of us kind of know that there's a problem. This graph, if you can see it, just talks about comparable countries. So this is the average spend, health consumption expenditures per GDP. So you could kind of see we've got this, we're in first place. We're in first place. So that's the good news. Bad news is it's not really a race we want to win that way. But this is where other countries stack up as far as their spend. Their curve tends to be a little bit flatter across the board. Ours is kind of escalating up. So there you go, just to kind of give you an idea of where we stack up from a global standpoint. From our perspective, this is the thing that really scares me for my clients, my family, is middle-class family share of spending on health was nearly twice as large in 2018 as it was in 1980. So in other words, you've got to fix, most folks have a budget, they've got a certain amount of income, and where's it going? So if this is the zero line, spending less food at home, transportation, clothing, furnishing, so spending less on those items, about the same on food and accommodations going out. Housing, surprisingly, was about the same, and other. But look at the healthcare spend at the bottom. That's where there's way too much money going to healthcare spend. So it's got to come from somewhere, and this is what we're reducing in order to pick up the extra cost on health. So just we're very cognizant of that when we're trying to design benefit plans and trying to find cost-effective ways for the employees to cover their dependents. Here's another way of looking at this: is how is the rising cost in healthcare, Medicaid in particular, because that's the easiest measure, impacting public assistance and education spending. So if you look at employee and education spending, higher education, public assistance, then Medicaid, transportation, corrections, all other. So this is essentially, think of this as the city budget, the state budget is what this is, so across the country. Medicaid used to be a relatively small portion of it, and look where it is now. As a percent of the total, Medicaid is eating up state budgets. And that's, you're wondering why our roads aren't getting fixed, why they're defunding higher education in elementary schools. This is why. So between 2008 and 2018, premiums for employer-sponsored plans went up 55%. What this isn't factoring in is we've been doing business for with a lot of you folks in this time frame. Is we went from $250 deductibles to $500 to $1,000 to $2,000 to $3,000 to $4,000 deductibles, doing HRAs, all kinds of stuff. So this 55% cost increase isn't factoring in the plan and the benefit design changes that we've had to institute to offset those costs. Average cost sharing for a family increased. So when I first got in the business, we had a lot of clients that were paying 100% for the employee and 100% for employers. You may remember those days fondly. Those were nice days. Now the average cost sharing for a family has increased 70%. So it's twice as fast as their earnings have gone up. So it's a big challenge for all employers. Employer and health spending on healthcare has increased faster than wages. So this is wages. I thought we had some other, there we go, premiums. So this yellow line here is wages. Those have gone up since 2008, fortunately, but not, and you all know this, not as much as what we would hope. Premiums have gone up, and then this purple line is worker share of the premium. So employees paying their portion of the premiums has gone up significantly, much more than wages, and even more than the premium cost itself. And this is kind of a real negative stuff. We do a lot of 401k plans. I think you know that. So it's, we see mutual funds and stocks and bonds and all that kind of stuff. What you're looking at here is, I think most of us, from an investment standpoint at least, might want to invest in some healthcare companies. So all these lines, this line down here is the S&P 500 index, so the Standard & Poor's index. That's when people talk about the market, that's kind of what they're benchmarking it off of, the S&P index. So this is the stock market from 2009 to 2020. The S&P went up 257% in that time frame. But look at Cigna, United Healthcare, Humana, Anthem, all the publicly traded health carriers have gone up. I mean, the green one's Cigna. Actually that's this one in here. You can't even see it, but I guess the purple one or pink, whatever that is, United Healthcare. We got a lot of United Healthcare clients, went up 1,000% in that time frame. So these insurance companies are making money. Don't let them kid you. And so what's driving all that cost? I'll take this slide, Riley, and then we'll jump into you. But these are the main drivers of cost: prescription drugs and medical devices. So prescription drugs have gone up tremendously over the last really couple years after the Affordable Care Act, that's where we really started seeing significant increases on prescription drug spend. Hospitals, the cost to go into a hospital and have an inpatient stay, or all the services provided by hospitals, has escalated quite a bit. Doctors' costs have escalated as well, and then all the testing services. So these are the things that are driving all of our costs. And we put this in here because what's interesting is, 20 years ago when I first started selling group insurance, there's a lot of things that weren't covered. In fact, you didn't have to offer a prescription drug benefit with your medical plan. So think about how crazy that would be now, right? So you didn't have to offer prescription drugs along with your medical plan. It was a rider. You added it or you didn't add it. And at the time, most prescription drugs were pretty cheap. That's no longer the case, as most of you know. So history shows that once a procedure is covered by insurance, its sticker price generally goes up because patients are largely insulated from the cost. So to this day, we still hear people who say, yeah, my copay is $25. It's horrible. That's, I can't believe a doctor makes that much money just for a visit, and thinking that that's the full cost. Well, that's 10% of the cost possibly for that visit. So things have changed quite a bit. I'm just going to skip over this. This is just more healthcare expenditure, where it's going and what's escalating. But hospitals lately are the biggest cost increaser. If you drive by Emmanuel, OHSU, Providence, you're likely to see a big crane out front. They're all doing renovations. They're all competing. It's an arms race for healthcare hospital spend. So, and that's driving this cost as well. So, out-of-pocket spending on drugs, physicians, and clinics. So this really is talking about, the employee share of all this cost. And as you can see from the graphs, just visually, there's an upward trend on what employees are spending out of their own pocket on, whether it's physicians and clinics, whether it's prescription drugs, or whether it's hospitals. Employees are paying a bigger and bigger and bigger percentage of the cost. And that's a huge problem because their wages have not necessarily increased significantly. And I put this last bullet point up here just to emphasize this. Uninsured and underinsured Americans often get less testing and fewer services than they need. Poor Americans are less likely to get crucial recommended screening for colon cancer, blood pressure, COVID, for example, those sorts of things. So if you're uninsured, you've got challenges. But the flip side of that coin is a problem as well. And the flip side of that is well-insured Americans suffer from too much treatment with tests. We have people, all the time, they're not questioning anything when they go to get care. The thing to remember about most physician groups that are fee for service is physicians and hospitals and facilities get paid when you use their services. So their motivation is often a little bit at odds with their mission, and that if you use their services, they get paid. So how do they get paid more? You use more services. So it's important for members to understand the dynamic when thinking about services that they're getting from a physician, a clinic, a hospital. Who they're dealing with is really, really critical. And then this is really just talking about how catastrophic claims have gotten bigger and bigger. I remember it was, must have been 10, 15 years ago. I don't remember the date, but, when we saw a $200,000 claim, and it blew our mind that there was a $200,000 claim from one of our members in our health plans. And we see those, I wouldn't say weekly, but we see those monthly for sure in our book of business. And we see a number of $1 million claims every year, So we're seeing more and more big claims, and they're getting bigger. And so a lot of folks, it's really just 1 or 2% of our population that gets those claims, but it'll eat up the entire premium budget for the year, that's for sure. And then this is important too. 70% of American households have less than $1,000 in savings. And so we see this in the 401k world. We see it everywhere. 45% of people have zero savings. It's hard to fathom. But my experience on the financial services side is that it's true. Most there's a good chunk of the population that goes paycheck to paycheck. And so when it comes time to pay their deductible, to pay their copays, to pay their coinsurance, it's a challenge because there's no reservoir of savings for that. 70% of those filing bankruptcy were due to medical bills had insurance. So they had insurance, but they still couldn't pay their percent of the cost. So it's really incumbent upon us to design plans that cover the member where they need to be. So that's kind of the doom and gloom. I would say the good news that we've seen lately, at least last year and this year, as good as it gets, is that the cost curve is flattening. So we were seeing really big increases, 5 years ago, 6 years ago, and even 3 years ago. That cost curve was going up pretty tremendously, and that's starting to moderate, and we're seeing smaller increases. And by smaller, I mean, high single digits. So don't get too excited, but it's still a big number, but it's not 17, 18, 20% increases generally, unless your group has significant claims and it's based on your rates are based on your claims. So that's somewhat comforting. But I'm going to Riley tell us, so what do we do? So what are the strategies that we found that work really well for our clients? We have over 500 clients, so we see a lot of different stuff. And we're in a national group where we see what's going on around the country. And so I think we're well positioned to assist our clients in strategizing on how they can contain these costs and give their employees a better outcome and a better benefit.
Thanks, Dan. All right, let's cheer this thing up, everybody. All right, and the reality is that stuff's important. We need to understand why, but let's focus on strategies now. Let's bend that trend a little bit. So this first slide, I think it's important because I still come across groups all the time. Why am I getting an increase? I got a decrease. I mean, where the heck are these magical percentages, coming out of, every single renewal? So what this chart breaks down, just in the state of Oregon, we're really separated with small group and large group. And that's that 50 FTE number that you see right now. So, under 50 FTE, small group, when you're fully insured, it's really two things. It's your demographic, which is your average age, and your location in the state. The location in the state isn't that meaningful. It's pretty darn close, but there are certain regions that, tend to be a little bit more than others. And then state filings. And here in just a second, I'm going to show you what that means. It's basically the carriers go, to the state every summer and they say, hey, these are what our plan designs want to be. This is where we want them, percentage increase. And the state goes yay or nay, kind of, based on the reservation stuff that they have. So over 50, it's a little bit different. You still have the demographics and state filings, but then you got something called experience, and that's claims data. So, you got some big ticket items, some of the things that Dan was talking about, those big catastrophic, procedures, prescriptions, things like that can really drive your cost up. We don't see that, under 50, FT. So that is one good thing about being, a small group, fully insured, is at least you don't have to worry about the big claims affecting your rate. But we can also negotiate rates, when we're over 50. So, we can use competitive data, really leverage, other carriers, and to get costs down a little bit. But right here, this is the insurance nerd in me right here. I get really, really probably too excited when this thing comes out, every single summer. What you're seeing right here, and this is public, by the way, this is on the Oregon State Insurance Commissioner's website, is that these are the preliminary rate filings for 2021. So again, this is how I can somewhat be Nostradamus for all my groups, in January, for 2021. And what you can see is that here's our local carriers, all these groups, and this is what they're requesting from the state, and then what the preliminary rate decision and kind of what Dan was saying. These numbers have been higher the last couple of years. A lot of it's been kind of about like 7 to maybe 15% increases. So we're seeing this flatten a little bit, which should be promising. But, what I look at this, I mean, Kaiser, for example, Kaiser still has the best small group rates. And that doesn't help everyone, throughout the state. But certainly those, in kind of a Kaiser, service area, you're fine. But you can kind of just get an idea. So if you're on some of these carriers that you're just noticing right here, when they just kind of break down what a 40-year-old, would look like on a silver plan, and on some of these carriers a little bit high, you want to make sure that, you're really shopping the market just to see what it looks like. So I love this stuff because it really can help my clients, budget a little bit. It's not always going to be exactly on, but, this is a really great way to kind of just forecast at least what we're thinking that 2021 is going to look like. So medical plan options when it comes to, fully self-insured, things like that. What this chart shows, for those of you, from 2 to 25 employees, you really got two options. You've got fully insured plans, and then you've got association plans. And I'll talk about that in a second. When you get to that 25 to 50 threshold, there's programs called level funding that I'm really excited to share, because we're seeing some success in there. And then 50 to, 50 plus really, it's everything that I just talked about, but then you've got self-funding plans, you've got captives, and something to keep your eye on. It's RBP, and that's reference-based pricing. We're starting to see, and I'm not going to talk a lot about that in this presentation, but if any of you want more on that, or if you're hearing about it, reach out to us and we could break down a little bit more. It has to do with Medicaid rates and some averages and such like that. So yeah, you can kind of see, and that's why I love, the organizations on this call. We're all over the board here. So let's see the next slide, Dan. The first thing is just kind of strategies within some of those platforms. And so, defined contributions, multiple plan options. We've been doing HRAs for a really long time. We're going to talk about that. Some performance networks. And then, of course, cafeteria plans. Not going to spend a lot on that, but just want to make sure that those are out there as well. So I don't know if we had a survey for this one or not, Dan, but, one thing that I found is that I still come across a lot of groups that are just offering one plan. And the reality is, there's no shoe size that, that fits all, when it comes to plans. That's why we see, platinum all the way to browns, all the different costs. So, a strategy that we certainly have with most of our groups is kind of a base buy up, buy down concept. So the example that we're showing here, let's just say for easy math's sake, the base plan is maybe a $2,000 silver, maybe, low of a gold plan, something like that. It's your traditional plan, and that's what you can afford. That's what your budget's set off of, whether it's you're paying a percentage of that or you just have a defined contribution that's exactly $400. So what other plans can you offer? So we like to do a, kind of a Cadillac Platinum plan, really low copays, low, max out of pockets for folks who just got stuff going on. I'm having a baby this year. I've got that surgery coming up. So, myself as the member, I'm going to pay a little bit more on a pre-tax basis, but it's still going to be less money, when I actually go to the doctor to get services done. And then on the other end, we do a buy down option. And in this example, we're pairing it with a high deductible health plan, which is an HSA account. So what a lot of our groups do is that cost difference, the employer funds the health savings account. I'm going to talk about HSAs here in a second. Another thing I like to do on that buy down is something called a family affordability option. And so it may not be a high deductible health plan because that's not always a great fit, for some groups, but, maybe it's just a high deductible, high max out of pocket, but, for a family who, maybe sees a doctor a couple times a year, have a few prescriptions, I just want to make that $400 go as far as possible, when I cover my dependents. And so, I like to call it, instead of a buy down, almost like a family affordability option. The next slide, and I think a lot of y'all know, how HSAs, high deductible health plans work. They've been around for a long time, but, basically, to fund and open a health savings account, there's a banking component to it. You got to have a qualified high deductible health plan, and every single carrier has these. And so, make sure that your consultants, are showing you these options. Just as an idea, you don't want to just offer this as your only plan because, the plan designs, everything's subject to the deductible. You want to be somewhat healthy or really funding that HSA. But to go back to what Dan was talking about, how, little, if anyone, has any savings these days, this is a great way to put money aside pre-taxed on an HSA, and it's your money. It just carries over every single year. So, always look into high deductible health plans. HSAs is maybe a second or a third option on your health plan. HRAs, we've been doing these for about 10 years as well. And, when we track stats, and it's hard sometimes, especially for groups, under 50, where we just can't get a lot of data. What we can do is get deductible and max out of pocket reports. So we started tracking these, and we had a lot of groups. It's like, goodness, 85 to 95, aren't even coming close to that deductible. So what this chart shows is that, you got about 80% of your group that it is. It's a couple doctor's appointments a year. It's your, immunizations, prescriptions, things like that. And then the other 20%, maybe it's a big shock claim, it's an accident, something happened, and then maybe just heavy utilizers that have, ongoing things. So seeing that, how an HRA works, or a health reimbursement arrangement, it's kind of a clever way if you still have a plan that's in that, maybe 500 to, up to maybe a $2,000 deductible, to increase the deductible just because you don't have a lot of folks that are hitting it. Save money because the premiums are going to be a little bit lower. But for those individuals, maybe that 15%, 10%, maybe even as low as 5% that are actually hitting their deductible, you as the employer funds the difference, in that deductible. So again, it's something that we've been doing for a while. It's just another strategy. If you're still on some of those platinum, low deductible benefits, you could be just spending a lot of money that, folks aren't utilizing that. So just something to definitely look into. We've got a lot of charts and calculators that we help our groups kind of assess if this would be a good fit for them. So tailored networks, performance networks, narrow networks, these have a lot of different names. And Dan, if you want to click, I think we got another chart that pops up here. But this is a way that carriers can offer plan designs and really shave about 10 to 15% off the premium, and basically just narrowing a network. Oh, you want to go back to that other one real quick? So what this breaks is, you see contracted networks. If you all are on a United Healthcare plan, you've probably seen their Charter and Navigate. If you're on Providence, they have their medical home plan where, your care is really kind of just focused, through your primary care. It's not just kind of a free-for-all to go to, multiple specialists because of just, that costs a lot of money to the plan. So this is something as, also you can add to maybe that third or second or third plan design as, hey, you know what? As our base option, we're going to do a narrow network plan, but if you really want to buy up to that full network, you certainly can. And then I think that next chart, Dan, if you want to switch over, this kind of gives you an idea just from a, a network standpoint. I think they're going to balloon here in a second. There we go. Graphics. So there's your kind of medical home, kind of your smaller network within the full PPO network. Then you see it blow up a little bit. So, level 1, level 2. And then, all doctors and facilities out of network. If you all have a, a Regents Blue Cross, a UHC, generally, you can see almost everyone, outside of Kaiser, if you're in the Portland metro area. So tailored networks, they're out there, something to keep your eye on, a great way to shave a few points. It's a little bit more member, centric. A lot of times on the enrollment forms, you actually have to list your primary care physician. Some people don't like that, but it's a great way to save a little bit. All right, association plans. So, an association is a way to, basically, use other organizations. You can see, in this graph, we've got, a bunch of companies that kind of share a risk pool. A lot of the times it's like, it's manufacturers or it's, professional organizations, things like that kind of have a certain component to, their business model. But it's nice for those organizations that really, in that first chart, from about 5 employees, really all the way up. When you get to be 100 plus, I think, I don't know if it's always a great fit, but certainly ones, that are kind of in that 25 employee space, things like that, where, you could be healthy, but maybe you're getting a little bit older. And so you see, keep seeing these demographic changes. So, one thing that comes into play, you can see to the left here, it's a GRX score. And I'm going to talk about that a little bit, in some coming slides too. It's a bit big brother, but it's just the nature of the beast here is that everyone's name and their date of birth is in a big old data system and it's tied to a prescription. So it can identify basically if you're a specialty drug utilizer, things like that. So you're going to get rated in a lot of these associations, but if it's a good fit, we see decreases. We honestly see decreases. And the nice thing from a broker standpoint, remember that we can't leverage rates, if you're under 50, but in associations, we can. We can use competitive data and keep rates down a little bit. I know that on this call, if you want to go to the next slide down, there's a handful of Cascade Employers Association members on here. This is a little bit of a unique one. And if you are a CEA member, you have access to this. And this is an association, but it's not necessarily a manufacturer or a nonprofit. If you just have a membership with the CEA, which is a fantastic HR consulting firm, you have access to this. So again, if you are a CEA member, let us know and we can run some numbers. If you're not, we can run numbers and maybe you'd want to join, as a member. So always look at associations. All right, level funding. I don't know if you want to do a survey on this one, Dan, if it's even possible, but if you can, That's great. If not, I'm going to tell a quick story. About 3 years ago. Oh, perfect. Yeah, y'all, if y'all don't mind, fill this out real quick. I'm really curious to see if folks have heard of level funding. This has been a great strategy for a lot of our groups.
All right, looks like most of the answers are in. Share the results. And it looks like, so level funding, who's familiar with this term? I've heard the term and understand the concept. That's 27% of you. I've heard the term but don't understand the concept. That's 40%. And then another group, another 20% said never heard of it. And that's what we're finding in the market is it's still an unfamiliar concept for most.
Yeah, so level funding, let's go back 3 years ago. And for me, I had a group that, I was getting about 15% increases just year in and year out. And this is a healthy demographic. They were just getting a little bit older. I had about 30 employees on the plan, and I was just getting angry. I ran a deductible report, and literally for 2 straight years, I had one employee hit their deductible. One employee, but I was getting 15% increases. And so I started doing a lot of research in these plans. And what this is, it's a way to kind of dip your toes into the world of self-funding without the fiduciary responsibility. And so you could do this, from really about 25 employees, all the way up, probably at 200 if you wanted to. And it's nice because, basically how it works is you have a fixed premium. So it's just like your traditionally, fully insured plan without that fiduciary responsibility. So if claims go up, you got a bad year, you're not going to be on the hook with that. And that's kind of the scary thing about self-funded plans. We're going to jump in that in a little bit. And if there's a surplus, you actually get some of that money back. So the next page, I'm actually showing y'all real numbers from one of my groups. And it's actually that same one. This is year 2. Now, this is a group that's renewing this September. So they've been doing it for 2 years. And, I rounded up just so the numbers look a little cleaner there. But essentially, 30 employees, they're paying $10,000 a month for their premium. All right, $10,000 a month. And you can see that it's broken up into 2 things, admin and fees, and then their claims funding. All right, so that's that 5 each, but it's really $10,000 a month. So their annual total premium is $120K. They're having a good year. Now, some of that may be, COVID related because folks can't go in and see the doctors, things like that. And, for the COVID environment on just not knowing, how are our renewals going to look? People aren't going in and there's just so much gray in that right now. This holds them a little bit accountable because we can track, we can see claims. So we can get a lot of data that you can't normally get on a fully insured plan, certainly in 100 employees. So again, we're having a good year. So we funded this thing $60,000. We've actually only paid out $30,000 in claims. So we have a balance of $30,000. All right. First off, our renewal came out. We had a 2% increase. And really the 2% increase is just because of some taxes and, just almost trend, and I think from a dollar standpoint, it equated to like $6 or something, for each employee. But because of that surplus, we're going to get 50% of that back. So $15K is going to come back, towards our invoice. It's actually the 15th month of renewal. But again, I could talk about this for an hour, but, I just wanted to share this concept because as Dan and I mentioned, we're just not seeing a lot of groups. It sounds like some of you all have looked at this. They do run a GRX score. So you either pass or you don't pass. So, they're kind of vetted out of the gate if they think this is going to be a good fit. So really high on this. We've got about, I think, 6 or 7 groups doing it right now. Now, I'm going to be fully transparent. I think we've got one group that this wasn't a good fit and we moved them away and they just got a higher, they got a high increase. But again, we could just go back to those state rates and, I don't think at the end of the day really lost out on much. But this is something that, if you think you've got a healthy workforce, if you want to take a look at it, definitely worth looking into it, especially if you can run a surplus. Cafeteria plans. This is kind of, Captain Obvious stuff. I have come across groups in the last 5 years that didn't know you could run your benefits from on a pre-tax basis from an employee standpoint. So make sure, you're running the employee portion, pre-tax with a pop doc. FSAs and dependent daycare, great value adds, to help offset, some of the, the employees' costs for health expenses as well as daycare. With the COVID environment, there's a lot of like relaxed rules and flexibility with changing the allotment. And that's one of the reasons I want to talk about this. Dependent daycare, a lot of times you got to sign up for that and you're good for the year. But what if daycare goes away, right? So, don't feel like y'all are on the hook if you're funding some of these programs. Make sure you're talking to your broker, your TPA, whoever's doing this. If you have some folks that want to pull out of this program, there's a lot of things that you can change right now during the COVID environment.
So
all right. Yeah, Dan, why don't you talk a little bit about self-funding, then we'll break some cost containment down.
Okay. So self-funding, that's sort of the next step on the whole thing we're talking about, which is, all right, and generally we start at 50 employees and above here. And it's certainly not for everybody because it really is a cash flow play. But a lot of people don't understand the concept between self-funding. So what it really is you're hiring a third-party administrator to pay the claim. Okay, so that's part one. And oftentimes the carriers that we're normally dealing with, whether it's Blue Cross, MODA, Providence, they all do this. So they act as the third-party administrator, so you can use them to pay the claims for you because they're already set up. So that's part one. You still have insurance to protect from large claims. So large claims on an individual basis, and then large claims on an aggregate basis for everybody. So there's still insurance to protect you from those large claims. And then lastly, there's a network. Okay, so the network is, you can rent a network, a national network. You can use Blue Cross's network. You can use Providence's network. But essentially, you're paying an access fee through the network. So those are three components that you need. And then underneath that is the employer basically saying, hey, rather than pay this insurance company this extra money, which I'll never see again if we don't spend it, I'm going to pay our own claims. I'm going to pay our own claims because I think we're a healthy group and we're not going to pay out as much as I think we are. Okay, so that's the concept of self-funding. And of course, the risk is you have a bunch of large claims and you got to backtrack, but you do have protection. So we always look to see what's the worst case scenario and can we handle that worst case scenario? What we find is that generally we don't come anywhere near that number. But we've partnered, because we're part of a national organization, we partnered with a group that is doing some interesting things in self-funding. So your typical self-funding group, almost out the gate, you're going to save in taxes and carrier profits. So this example, what you're looking at is, here's a group that has $1 million in premium for easy math. So we're fully insured. We got $1 million in premium. Let's go self-funding. Instead of using Providence or Blue Cross or MODA, Pacific Source or Health Net, let's do it ourselves. We'll hire a TPA, we'll get the network, and we'll do this, okay? So right out the gate, you're going to drop your costs, okay? Because typically your admin cost is going to be a little bit less, but you're avoiding a bunch of taxes because it's a federal, it's under ERISA as opposed to state mandate. So there's some tax savings right there, which typically roll up to 20 to 35 per member per month. So pretty good chunk of change. And then you don't have to worry about the carrier profits because, believe it or not, even Providence, which is a nonprofit, or Kaiser, which is a nonprofit, they're not nonprofits in any sense that you and I would recognize. They're making good money, particularly if you look at their stock price for the nonprofit publicly traded health insurance carriers. So with self-funding, right out the gate, you're saving a chunk of change. All right, and one way to think about it is, it's today. What happens 10 years from now? You saw those curves. Those cost curves are going up and up and up. So how can we bend that trend? So what this slide is trying to tell us is you've got your fixed costs. You're going to have those. You've got your insurance costs. You're going to have those. You're saving on taxes and carrier profits. So where's the opportunity? And the opportunity is something found somewhere called cost containment. When we're fully insured, we have zero control in the cost containment. We can do a wellness program. We can encourage teledoc. We can talk about not using the emergency room when it's not appropriate. And we do all of that stuff. And we do the best we can to educate. But particularly in our smaller groups, we have zero transparency into what's going on behind the curtain from a claim standpoint. How are people using the plan? And that's where cost containment comes in. So some of the interesting things we're seeing out there nationally for self-funded plans in the cost containment world, we're going to have Riley talk about that. So
yeah,
Riley,
I mean, literally the weekend prior of everything kind of happening with COVID, I was in Coeur d'Alene, Idaho, actually with this partner that, we were so excited to talk about this program. And I literally just had my mind blown. I mean, I've been doing this for a long time, but what this organization is doing from a cost containment standpoint, it's unheard of, and I think for those on this call, certainly in that 100+ space, if you've ever kind of been afraid of because of that fiduciary responsibility, I would look into some of these programs. I was sitting next to a group, it was actually a ski resort up there in northern Idaho, and they were getting 25% increases every single year on a fully insured plan. And they've been on this program I'm going to break down here in a second. It rate holds the last 2. So cost containment, what can we do to keep these claims down, and so we've got multiple transparency tools. As Dan mentioned, prescriptions are huge. Providers, and this is for everyone on the call too. This isn't just for the large groups, because, narrow networks is really kind of a provider situation too. Wellness and health coaching, goodness. I mean, as the HR professionals on the call, it's hard to get that organized. I know we all want to do stuff like that, but no one has the time. So how can we really get those off the ground? Telemedicine, things like that. But at the end, it all has to be member centric. So how can we have, outbound calls, claim scrubbing, things like that? So I'm going to start, let's go to the next slide, just kind of start breaking down some things. So this is a chart of an organization where you can just kind of see, total spend on prescriptions. Oh my gosh, one of the key drivers to all of this stuff. Goodness sakes, they're expensive. And, I heard this stat, a couple years ago that 90% of doctors don't know the actual physical cost of what they're prescribing you. And that's not a knock to the doc. They just don't have time to research what plan you're on. They don't know if you're on a Providence plan or a Blue Cross plan. And is that prescription into their formulary or anything like that. So, RX, for those who have had really big increases in the large group scales, you probably know there's probably some significant, prescription claims. So, how can we get some of these prescriptions, under control? So you can just kind of see here, in this example, just some diabetics in the company, that it's a lot of money. So if you look at the savings, these are some actual, like mail order programs that are overseas. And I know that sounds a little bit shady, but these are the same exact manufacturers that Walgreens and everyone else is getting them from. Dan, if you go to the next slide.
Yeah, and I did want to point out a couple other things. So this was an actual client of our self-funded partner. And you start looking at the breakdown, and it's pretty shocking. So if you look down here at pregnancy care, so this is where, so there's 9 pregnancies at this time. There were 9 pregnancies in the group, and 9 were not compliant. Okay, so one of the things that you can do if you're self-funded, if you've got a real good partner, is they're data mining, and they're trying to figure out, okay, we have pregnancies, we know they did their initial meeting, but nobody followed up. They didn't go see their physician. Or the well child care, there's 113 members in that category, but 52 are not compliant. So it's really just tracking the data and then having somebody reach out, whether it's electronically, whether it's with a phone call, whether it's suggesting a different prescription drug, or whether it's suggesting you go in to do a well baby exam or something like that. All of those things, even though it might cost a little bit more money to send somebody in to see a doctor, it seems counterintuitive. Keep it, keep the small things small and keep them from getting worse. And that's kind of the whole concept behind data mining, which is what this slide is really talking about, is mining the data in your group. And it's not you mining the data. And that's the thing. You don't have to do this. You want to have your TPA or your partner, your consultant, data mine and find those gaps in care. So that's what this is really doing, because you'll be surprised. Most people don't go to the doctor, particularly if it's guys. They're not going to go to the doctor until it's fallen off, right? And so you really do have to make it easy for them. And by doing that, you can lower the overall cost of your plan significantly.
And these concierge type services, a lot of times, it's these big specialty meds, and a lot of them need a pre-auth. So, that sparks the plan pretty quick. They see that pre-auth, and that's when the engagement starts. What can we do to treat this, with the best outcome base? And this is a good segue to this, but also that's going to save a little bit. This tool that y'all are seeing right now, if anyone is on a Regions Blue Cross plan here in Oregon, you have access to this. This is actually a med-savvy screenshot. And I hope that, more carriers start having this, included at no cost. There's some free versions of this that we have in the paperwork that we're going to send to everybody. But, what we're finding is that, you get diagnosed with something or you need a prescription, your doctor prescribes it, you go to your Walgreens and, here you are, you're taking this one in the middle here. for diabetes, and it's, oh my gosh, it's 429 maybe to the hospital. For me, it's like, $60 or something, but it's outcome-based rating. So you can see that this is a C. And what this program does is if you plug it in, it'll tell you a generic equivalent or maybe a lower cost, where to find it. Again, outcome-based. And in this case, this one over here, it got a better grade, at a B. And so this just gives, the members a little bit more control. And this is, even outside of self-insure. This is nice because a lot of the TPAs use programs like this when they are doing the data mining. But even you members, if you're on an HSA plan, for example, that, everything's subject to your deductible and you got a big medication, you could use tools like this, to keep the cost down a little bit. Another thing is just, how are we connecting with our physicians? Telemed, and I'm going to talk a lot about this here in a second with COVID, but, utilizing doctors, virtual visits, saving those dollars, just, instead of having to take a half day of work, things like that, using these resources to do it remotely, all that stuff. For those of you that are kind of in rural areas of the state, even getting second opinion. And Dan, we were talking about this yesterday, something ridiculous amount of, surgeries. I don't want to say they're botched, but they're not really helping, the employee. It's over 50%, of a lot of surgeries aren't even, helping, and then that leads to another surgery, so the cost just keeps ramping up. So, there's a lot of
the stat in the medical field is depending on the condition, there is typically a 25 to 40% misdiagnosis rate. Misdiagnosis. So how would you like to have a type of cancer, but it's misdiagnosed as something else because you didn't have an expert looking at it? And it's just logic. I think sometimes it's like we trust our doctor, but the reality is that they're trained just like anybody else. So, a general practitioner is not necessarily going to see, various types of cancer every single time, particularly if they're in the rural areas. And so you do want an expert review. I know if I had a diagnosis, I would want to have access to a second opinion before, they stuck me in the hospital and started cutting on me. So, that would be really critical. And those things are out there, those tools are out there, and they're very affordable. So.
Even, in Portland Metro, let's just say, one of the Providence Hospital Legacy, and I'm just not happy, or I really want that second opinion, you can use this technology to go right to, the Mayo Clinic or a Center of Excellence. So it's pretty cool. Another thing, sometimes we just think if it's more expensive, it's always going to be better. And it's really not the case. Dan was talking about these extravagant hospitals. I've been in some hospitals and they look like ski lodges. They got giant fireplaces and stuff. And that doesn't always mean you're going to have a better outcome. So, be really careful about that stuff. The hospital that's doing more surgeries, they're seeing it all the time, you may want to go there, instead. So don't be fooled sometimes. And that's really what this slide, showing, just because you got this beautiful hospital, that does not mean anything with outcome. It really doesn't. And this is, oh my goodness, this is a fun one to talk about. Medical tourism. Holy smoke. Can you believe it? Actually leaving the state, leaving the country, getting prescriptions overseas. And this is what's happening until we get some type of reform, whether it's pharmacy reform. This is what's going on. So, this organization that we have this new self-funded plan, they're no joke, flying folks to San Diego for certain procedures. You get put up in a really nice hotel, a very nice car picks you up, takes you to Tijuana to get the surgeries done, and you're saving literally 80% of the cost, and it's a wonderful experience. And I know this sounds absolutely ludicrous, but this is what's going on right now. There are a lot of prescriptions, so many prescriptions, again, from the same exact manufacturers that you would buy at your Freddy's or your Walgreens, that you can get from overseas via mail order, and you save 80%. So, a lot of the medical RX tourism, there's some really good articles out there on this stuff. The state of Utah, the state employees of Utah are doing this now. And I think there's about 15, maybe 20 medications, certain procedures where they're doing this. They're actually going to this facility in Tijuana. It's a nice place, and that's how it's working. It's helping them. So you're going to see more and more of this type of stuff. And just know, even here in Oregon, we have access to these types of programs. And again, going back to kind of medical transparency, we talk about this a lot in our market up here in Portland, is that just the discrepancy, just the difference in cost of the same thing. I mean, I use the example of Providence St. Vincent here up here, on the west side. It's like the same MRI is $800. If you go to the Epic Imaging, which is only 2 miles down the road on 26, it's like $300. Same machine, same everything. So again, tools that can say, no, don't go to the hospital, go here, and we'll help you get in there and make it so easy for the member to help contain cost is always really good. And a lot of y'all, even in the small group space, have kind of transparency tools on your websites, so make sure you're taking advantage of those. And then wealth, I'm not going to spend a lot on this, but again, it's hard to get these off the ground. We talk about them, the carriers talk about them, and unless someone really just handholds and does it, it's tough, to get any type of wellness, health coaching off the ground. So again, a lot of these TPAs that are almost like concierge services have really seen proven results, with Fitbits or, fun games you could do with the staff just to keep, physical health, but also mental health, morale, all of that type of stuff. So not going to talk a lot about this, but there are ways, if you really want to just dive into this, to make your wellness programs better, they're out there. Okay, now I think we've only got about 5 minutes, so we're going to kind of rush through a little bit of this stuff, y'all. But, this is technology, and this is really just COVID related. And a lot of this we've talked about. So use technology. We don't know how long this is going to go. Almost all of you probably have, the doctor on demands and the teledocs. If you go to the next slide here, Dan, telehealth services, because of what's going on, the rules are changing a little bit, how doctors are getting paid via teleservice, all of this stuff. So I want to say that I think telehealth was up 300% in April, April, May, and June, obviously, because you can. And I think that's a good thing. I think it's kicking the training wheels off a little bit when it comes to, using technology, talking to your doctor. Hey, that was actually really easy. I just got my allergy meds filled, just over the phone, and it was free to me, or it was only a $10 copay. So every single health plan has some form of teledoc, okay? So make sure you're talking to your brokers and consultants, getting that information out, to your members, email blasts, whatever it is, just to make sure that they have that ready, and downloaded. And this, again, the things we do, we're big on education. So if there's any clients on here, us, I mean, we're always talking about this. I give lottery tickets out, to folks who download it the fastest and stuff like that, because the reality is that when you actually need to use this stuff, you forget about it. So, make sure, again, that you're getting flyers out in your break rooms if you're back from being remote. Certainly when everyone's back, in their normal office spaces, I think that this is going to pick up, 24-hour nurse hotlines. Again, every single one of you have access to this on your healthcare plan. A lot of this stuff kind of falls between the cracks. Online enrollment platforms, we started doing this a few years ago, really just to take a lot of work off our client's desk, and just kind of streamline the process. And man, I'm glad we're doing it because, can you imagine being remote, 100 people on the plan and having to, change carriers with paperwork and enrollment forms and all that stuff. So, online enrollment platforms, they're getting more and more sophisticated. They're starting to have direct EDI feeds. EDI feeds are, when these platforms actually talk to the carriers and give them the enrollment forms. A lot of groups 200 plus probably pay for this or things like that. But even for y'all in smaller organizations, a lot of the dental lines, ancillary, you can embed in this now. So, modernize the benefits experience. I know tech's a little behind when it comes to this stuff, but it's catching up fast. So definitely, third, fourth quarter, make sure you're using that. And what we do, in this, Dan and I are talking a lot. We do a lot of these types of presentations. We can record them. We put them on the employer's website. We put it so new hires are getting them, all of that stuff. Because again, this stuff is confusing. So how can we best, relay all of this information so your staff's using it effectively? This is cool. Dan, you want to talk about Jellyvision?
Yeah, so this is a new product that came on that it's been on the market for a little bit, but we just started using it for some of our clients. But it's basically an interactive enrollment software is what it is. And so it's got this character called Alex, you can see there in the corner. And what Alex does is walk your employee through the benefit program and help them make the best decision. So if you got a medical, maybe you got 2 or 3 medical plans and you got an HSA plan, and maybe you got 2 different dental plans, you got some voluntary life and disability and, all that type of stuff. And it just walks them through that process of enrolling and help them make those decisions, including the 401k decision or the flexible spending account decision. And it's very, it's very well put together. It's based on your benefits. And at the end, they get a little handout that they can say, okay, I'm going to do this, 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 and this on my benefits. And so it's pretty cool because I've been doing education meetings for, 20 years. And I can tell you from experience that a lot of employees have a question and they're not going to ask that question in a group setting. They don't want to ask the HR person, and they're never going to get it answered. And so this is what we find when we've used this, and we haven't used it a ton yet, but the experience so far that we've had with it is that the employees are a lot more engaged is the feedback that we're getting. So if you're interested in getting more information on that, we really like it because it's hard to communicate benefits in a way that makes sense to everybody. So.
And then EAP, oh my goodness, EAP, and I'm happy to see that a lot of the carriers, medical carriers, are starting to embed this in their plan. Because mental behavioral health, it's real, and it's harder and harder to see people, all of this stuff. So, we talk a lot with our groups with, what we consider highly perceived benefits at a very low cost to the employer. And, if EAP isn't embedded in your medical plan, if y'all have disability, sometimes it's embedded in your disability plan, but even standalone, it's just a couple bucks a month. And I'll tell you, being able to have, that complete confidential, counseling service for you or anyone in your family is so important, especially during this time. So, if you have one of these programs and you're not talking about it, talk to us, talk to your broker. Let's make sure we're getting this information out everywhere. We always like to get, magnets to put on the staff, break room fridges and just stuff like that. But, EAP, the importance of mental and behavioral health right now is as high as it's ever been. So if you don't have an EAP program, look into it. As I mentioned, it's really affordable. It's a great thing to have. So I know we're kind of wrapping up. Well, it's 12:30, and it looks like Jennifer said we're actually supposed to go to 12:45. But I think an hour is pretty good, for everybody. So I don't know, if you want to spend the next few minutes, if folks had some questions, if some folks want to read to it, or kind of how we want to close this. But definitely appreciate everyone listening to us go for it here.
We did have one question in the chat window, Riley, if you'd like me to read that to you from Deb. Well, actually, let's going back to, you touched on it a little bit, but she was wondering about shouldn't insurance costs go down because people are not going to the doctor, and how is that going to affect costs moving forward?
Such a great question, Deb. And I've got business owners that are close to lawsuits with the carriers. That's really what it's come down, and especially with these first 3 months. And what the carriers are telling us is that hopefully, and especially in that large group space, with utilization, that we should see decent renewals. But what they're also saying is that they're subsidizing everything COVID related. So if y'all need a test, if you need if you certainly get diagnosed at this hospital, that's free to the member. The hospital's not covering that, at no cost. And so, the insurance carriers are on the hook for a lot of that. So they say. Now we know that they're going to get bailed out a little bit too. But, medical aside, we are seeing rate holds across the board on all disability and life insurance. And actually, for the first time yesterday, I have a large MODA dental group. And if any of you all have MODA dental 50 plus space, you may have seen this email. They actually are going to reimburse because of the dental office is shutting down. So what we have found throughout this whole COVID, experience the last 4 or 5 months is that it's kind of like a game of follow the leader. One carrier will say, hey, we're going to do it this way. And then they all do it. Whether that's right or wrong, I guess it's right that at least, some of them are taking initiative. But from the medical premium standpoint, there are so many unknowns. And Dan, I don't know if you had any, feedback on that, but, it's really just kind of a wait and see. But I'm hopeful that obviously because the claims are down a little bit, they're also telling us that they're seeing an uptick of, folks coming back in now, things, everything have opened up too. But again,
we'll just have to see, right? So Deb, it's a great question. So in small group, we have zero control over it, right? And they filed their rates, and we're hopeful that if this trend stays the same through the end of the year, with utilization, and I don't know if you've seen it at your clinic, but what we're reading is that 30 to 40% reduction in utilization across the board on our medical, on our insurance claim, as far as insurance claims. But because small group has already filed their rates, what does that mean? So unless they refile later in the year, we probably won't see any change in that. Now in large group, where it's going to be claims based, we'll have a great negotiating power because we'll be looking at, at least 4 or 5 years out of the month, 4 or 5 months out of the year where claims, and we're already seeing that when we look at utilization reports. We're seeing 50% utilization, 60% utilization, 30% utilization on a lot of our large groups. And so that is going to lead us to be able to, in just a stronger negotiating position when renewal comes around. So I think you had another question, which is, and I'm not sure Riley knows this answer, but regarding the Med Savvy tool that you showed regarding the prescription drug benefit, where does the data come from Med Savvy to tell us this drug is an A, a B, a C, or a D?
Yeah, I know that it's not just for regions. Well, wait a second. Why is this region? It's all their data. And it's bigger than I can get that information. I don't want to mislead anybody. I know that it's 100% outcome based, which is, in my opinion, it's the most important. But, well, how many are actually in that pool? Whoever answered that or asked that question, I can get that answer from you. So, yeah, let us know. Send us a note. And what I'll do is I can get exactly where the Med Savvy stats come from.
Yeah. Yeah, I think it's basically a third-party research firm basically doing all the research. It's not the insurance company. They actually buy the data from a company that looks at prescriptions. I do know that. I just don't know who they buy it from. So, all right. So I think that's kind of it for the questions. So thanks for attending. And you want to wrap it up, Riley?
Yeah, no, just like I said, hope everyone's doing well out there. And then, this was a helpful, it was an hour. I know it's a lot of data, but, we feel that it's really important to know, what's going on out there. And, Dan and I try to do a couple of these each year for those in that, really 85 employee plus space. If you want more information on the self-funded platform that we were talking about a little bit, reach out. It's pretty cool. It really is. And we may even do a bigger, webinar specifically for that later in the year. But, for our clients on the call, thank you for joining. It's always good to see your names on there. And if, any folks who aren't working with us, we'd love to help you. So, just let us know. We can take a peek at your plan and see if there's anything we can do to use some of these strategies to help you, especially if you're not getting that from your current consultant. So.
And then lastly, so there's a handout that we have that has some of the data in here, plus the slides. And then we also recorded this. I think we're sending out the recording. I'm not sure what we're doing with that. Jennifer Bugley will let us know. But all this data from this presentation will be available to you. And if you have questions, don't hesitate to circle back. And Deb, I'm going to do some research on that Med Savvy thing as well, so we can dial that thing in. Okay. All right, gang. Well, thank you so much for attending. It much appreciated. Thanks for the time, and I'm sure we'll be talking to you at some point soon. And stay healthy. Bye, everyone. See you, Tina.